All right. Hi, everybody, and welcome to MSECT and to today's webinar titled Nautilus ECMO Oxygenators. And we're going to share the European experience. So this webinar is also a sponsored one by Medtronic. Just some practical information. All microphones and cameras are not active, but please feel free to use the Q&A for sharing any questions with me, and I will make sure your questions are addressed at the end of the webinar. My name is Jesse Wouters. I'm the Senior Product Specialist of the ECLS and cannula portfolio of Medtronic, and my responsibility also goes over Western Europe. So because this webinar is all about sharing the European experience within Medtronic, we thought it would be maybe interesting as well to also have a European moderator. So with that said, it's my pleasure to introduce you to our first speaker, which is Kalynne. Kalynne is a South African-trained perfusionist who moved to England in 2019 to the Royal Brompton Hospital in London, where she completed her registration under the Board of Clinical Perfusion Scientists of Great Britain and Ireland. And Kalynne will today share clinical experiences from within the Royal Brompton Hospital in using the Nautilus ECMO Oxygenator and the impact it had on their ECMO patients. So with that said, Kalynne, the floor is all yours.
Thank you, Jesse. Good afternoon, or should I say good evening to some of us. I'm a clinical perfusion scientist based at the Royal Brompton Hospital, as Jesse's mentioned, in London. I'd like to thank Medtronic for the opportunity to speak about our experience with the Nautilus Oxygenator, specifically during the COVID-19 pandemic. So just a little bit about the Royal Brompton. It's a specialist heart and lung hospital based in Chelsea, West London, that offers an ECMO referral and transfer pathway comprising of a specialized retrieval team and extracorporeal life support unit. I started working at the Brompton around November of 2019, only then to have the COVID-19 pandemic hit in early 2020. And so between the years of 2020 and 2021, the Royal Brompton was the largest provider of ECLS in England during the COVID-19 pandemic. Within these two incredibly challenging years, we retrieved around 187 COVID patients on ECMO from all over London and Southwest England. And at the height of the pandemic, we had 25 manned ECMO beds in adult intensive care at one time. The capacity itself was largely challenging, as I'm sure you would imagine. Staffing requirements were quite burdensome, as patients required 24-hour bedside supervision. Myself and my team worked round the clock with circuit maintenance, CT runs, physio, decannulations, and circuit changes. In fact, we changed approximately about 144 circuits throughout this period, of which we used approximately 82 Nautilus oxygenators. Given the high turnover of ECMO circuits throughout this period, we were quite conscientious of the properties of ideal ECMO oxygenators, which is just something that's compact, biocompatible, and provides a low resistance to blood flow with long-lasting and efficient gas exchange. So essentially anything that provides a minimal inflammatory reaction, limited absorption of clotting factors, which leads to bleeding, and minimal pressure drops that are friendly to blood components. So decreased hemolysis, platelet activation, and again, a reduced inflammatory response. I've put out the Royal Brompton indications for a circuit change. So this is directly out of our protocol. So obviously anything that indicates an oxygenator failure characterized by a decreased post-oxygenator PO2 of less than 20 kPa with an FiO2 of about 100%, an increase in carbon dioxide, despite increased sweep gas flow rates, rising transmembrane pressures, and concomitant reductions in blood flow, or pre-membrane pressures of over 300 millimeters of mercury. We'd also look out for oxygenator fiber leaks, excessive clot formation, or fibrin strands anywhere within the circuit that could become dislodged and potentially lead to an embolic event. Any evidence of consumptive coagulopathy, such as rapid hypofibrinogen or thrombocytopenia, and increased bleeding from the patient, steep rise in D-dimers, although this value alone should not be an indicator and should be taken in conjunction with other sedative factors. And then any rupture or leak within the circuit that renders it unsterile or likely to fail. When deciding to do circuit changes, we also have to consider the clinical implications of them, and any potential patient adverse outcomes. So I've just listed a few that we obviously take into consideration. So any patient that's highly dependent on flow, any flow interruption can cause an adverse event. Again, there's always the potential for exsanguination, considering the major vessels that are cannulated. There's always room for some human error in these situations, which are done quite quickly, and that could lead to incorrect configuration or air transfer. But I think specifically to note is the systemic inflammatory response that is induced every time we change the circuit. The inflammatory response to ECMO is quite complex and multifaceted. In summary, it arises principally due to the contact and complement systems becoming activated as a result of blood exposure to the circuit. The combination of a sustained innate immune response and the pro-inflammatory aspects of coagulation result in endothelial injury, with a lot of leukocyte activation and the production of pro-inflammatory mediators. And this is what ultimately causes end organ damage in our patients. So this then leads me to the heart of the presentation, which was a patient who had a singularly extraordinary run on ECMO. I'll refer to him as patient X from here on out. He was a 43-year-old male that we retrieved from Northwick Hospital Park in February of 21, who was suffering from severe COVID-19 pneumonitis, was unresponsive to proning, hypoxic, and quite hypocapnic. If we look at the timeline of his ECMO run, he again was put on ECMO around the 7th of February 2021, and then put onto his first Nautilus oxygenator on the 21st of February. After which he was on for an extraordinarily long length of 164 days on a single Nautilus ECMO oxygenator. Considering how long this run was, I decided to pull the oxygenator function data throughout the course of this run just to assess it. And so I looked at the trending daily average transmembrane pressure first. So as you can see, there is a steady increase throughout the 164-day run, and there is this almost anomalous kind of jump around day 40, which in the notes, in patient notes, was according to a faulty transducer dome at the time. But yeah, with this increased or slowly increasing trend, it was still well within our considered healthy parameters of a transmembrane pressure in an oxygenator. I also looked at membrane resistance, which is a Royal Brompton-derived factor that we record, and it's a ratio of transmembrane pressure to flow. There's no absolute indicative value of a membrane resistance factor, but it rather aims to track a trend of the transmembrane pressure in relation to flow in order to identify increases in transmembrane pressure which are not flow related. So obviously in the instance of a failing oxygenator. So if you look, there is a definite increase in daily average membrane resistance throughout, indicating that the oxygenator was obviously aging and tiring throughout the period. So the next logical thing to do would be then to look at the quality of oxygenation. And so I looked at the daily average post-oxygenator PO2. And as you can see, it did decline over the course, but quite slowly and over steady increments, and still well within what we would consider a therapeutic range in terms of delivering oxygen. I just then plotted the daily average membrane resistance and post-oxygenator PO2 for you to see. So again, there is this increase in membrane resistance, however, not affecting the overall therapeutic range of post-oxygenator PO2 that's being delivered to the patient. I also had a look at the average daily carbon dioxide, arterial carbon dioxide levels versus the rated sweep flow being delivered to the oxygenator. And so again, throughout the course of the 164-day run, he had quite stable PCO2 levels. However, there was an increased demand in rated sweep flow to maintain these levels, I would say, towards the end. And as you can see, right at the end, we were requiring about 11 liters of sweep through this oxygenator to maintain the PCO2 within the ranges that he had previously throughout the run. I also had a look at the some of the factor consumption data. So basically just looking at platelet counts and plasma fibrinogen levels. And I think this is probably one of the most significant points to note is with regards to his platelet count, is this patient didn't actually receive any platelets while on this circuit. And in fact, there is an increasing trend in his platelet count throughout his run, which is quite an interesting fact. And then having a look at his fibrinogen levels, he did actually receive 3 cryotransfusions within the first 40 days on this circuit, but nothing further on this specific run. And if you look at the trend, there is, again, quite a stable, almost increasing trend throughout his fibrinogen levels throughout the 164-day balance of 164-day run. And so ultimately the question is, why did we change the circuit? I think around the 164-day mark, we registered a PO2 level, a post-oxygenated PO2 level of around 22.5, which is just above our threshold cutoff level for a circuit change. I think that alongside a increased rated sweep flow demand perhaps indicated it was time to change the oxygenator. And so this then leads to the question, was this an optimal ECMO oxygenator run for the specific patient? And considering how long-lasting and efficient the gas exchange was in the face of quite a stable transmembrane pressure, I would say yes, this oxygenator certainly did what it was set out to do for this patient. And that's it. Thank you very much for listening.
Thank you, Kalynne. Thank you for sharing the Royal Brompton experience with the use of the Nautilus ECMO Oxygenator. And again, to point out, guys, don't be shy. Use the Q&A for sharing any questions with me, and I'll make sure at the end of the webinar that we address all those questions to the speakers and try to answer them in the best possible way. All right, so let's move on, and let's move on to Mauro Cozza. So it's my pleasure also to introduce Mauro Cozza to the stage here. Mauro is the ECLS ECMO unit coordinator also the perfusion service coordinator at the Policlinico San Donato in Milan, Italy. Mauro is also actively involved in clinical research at the Policlinico San Donato. He is author and co-author of several scientific publications in index journals and book chapters related to ECMO and management of coagulation and anticoagulation in the field of extracorporeal circulation, ECLS, and mechanical circulatory support. And today, Mauro will highlight the San Donato experiences with the Nautilus Smart ECMO module and the impact that Nautilus Smart has had on monitoring and managing their ECMO patients. So with that said, Mauro, please feel free to share your screen and unmute yourself so you can present on your slide deck. And again, don't be shy to share any questions in the Q&A, guys. So.
Okay. So thank you very much for this opportunity. It's a real pleasure and an honor to be involved in this sharing meeting of our experience with the Nautilus Oxygenator. And so thanks to Jesse and Medtronic Hall. I would like to start from this statement of Professor Pater Bomesch from Yale School of Medicine about the troubleshooting that can happen in a bedside environment. This statement is particularly important for our daily practice. And it states a culture of safety should be emphasized to optimize patient outcomes. So working on safety in general means that we have at the end improve the outcome and so guarantee performance of our ECMO system. It means also preventing complication and as well managing any kind of complication as well, or better, the ones that we are able to manage in a correct way once they occur. And the problem is that complication, as you know very well, during ECMO are quite common, and we can distinguish mainly two kind of complication, which the ones that are patient related and the one that are ECMO related, as we can see in this picture that I extract from the International Summary Report from the ELSA registry. When we talk about safety on ECMO, every one of us have to identify the area of risk of the process and of the procedure that it is going to attend. So in the ECMO area, generally, the area of risk are the one that is correlated to thrombotic issues and impaired gas exchange. So once we are on ECMO, we have to remember that the therapy is a dynamic therapy, and it requires a dynamic response. So probably we have to move from a old paradigm that was just observational approach to the ECMO to a preventive approach of what happens in terms of complication during ECMO. Till predictive, that means that we have to understand which are the leading cause to an event is going to occur. How we detect complication during ECMO? We should for sure have reliable data, and I we will talk about several times about the idea of reliable data. What we learn from the ECMO, from the COVID experience, but we learn it every day, even in extracorporeal cardiopulmonary resuscitation, is that during critical scenarios, we generally have a lack or at least a delay of information. And what makes the difference in this condition is the expertise of clinicians that are involved in the ECMO support. The problem is, the bias is that this expertise depends mainly from the number of ECMO to which you are exposed, and so the number of complications that you are exposed and you are involved to solve. So if you are not an expert, what you can do is to get experience from other expertise, from the experience of others. And these allow you to be involved in structured algorithms that comes from experience of the others. What means implement algorithms? Well, algorithms are useful to timely detect complication and on the other side to minimize as well as possible any possible confounder. They are mainly based on literature consensus, but what is important is that any kind of algorithm of behavioral algorithm, particularly during ECMO, is that they rely on reliable indicators. These reliable indicators have to be in a correct number in order not to conflict with the previous statement, which was minimize confounder. This is, for example, our algorithm to manage anticoagulation during ECMO. And as you can see, there is a minimal number of indicators, but there are. We consider that we understand which one were reliable according to the positive predictive value of each single indicator. So where to find this useful indicator? And the easiest thing is to find indicators clinically in the clinical side during ECMO. So as you can see, we generally approach to ECMO understanding how these indicators are providing providing any SELS support according to goal-directed perfusion goal, so that at the end, what we want to understand if our patient is hypoxemic, normoxemic, hyperoxemic, and taking care of the idea that there is even a contribution of the patient with variation of cardiac output and of course is residual native lung function. On the other side, we have indicators that like the one that you obtain from lab values, point of care test, and transmembrane pressure that give us the situation according to the management of anticoagulation efficacy during ECMO. And this can give us information about the patient, about his hemorrhagic, pro-hemorrhagic, or pro-thrombotic state, but even also the integrity, the capacity, how we are able to prevent the integrity of our membrane lung. So according to this information, we can understand, combining this information, if we have an oxygenator that we keep in place or we have to replace. As we said, indicators during ECMO support are mainly correlated to gas exchange and the efficacy of anticoagulation during ECMO, preventing membrane lung. The first one was we can summarize in management of oxygen transfer, and so the two levels of hyperoxia and hypoxia. We know very well that moderate hypoxia even moderate hypoxia is associated with increased mortality in VV ECMO and also during extracorporeal cardiopulmonary resuscitation. So this means that you should have the possibility to modulate the level of oxygen in order to prevent any sort of neurological injury, and so that the reoxygenation must be titrated in a safe range. So the problem is how much easy or how simple and safe is reducing VO2 according to the minimal level of VO2 in order not to injure the patient itself. On the other side, we have the opposite problem, that is hypoxia. And so we are going to find indicators, early indicators that can suggest to us how safe is the management of the oxygenator according to failing O2 supply that can depend from wall bottle supply or the gas line of the oxygenator. And on the right, the other effects is how much DO2 we are able to supply to the patient. And this can depend from obviously the O2 supply, but even to try to understand through a differential diagnosis if the hypoxia that we have depends from oxygenator itself due to a failure of gas exchange, or increasing in transmembrane pressure, or a problem deriving from native lung, or a modification of the native cardiac output, or at the end a pump failure. So we said before that the other indicators are related to membrane lung integrity. So we can, in a funny word, we consider it not hemostasis but hemostasis, because we know that there is a synergistic effect during ECMO in which we have hypercoagulability, stasis, and even the other promoter is the endothelial injury. Every one of these passages leads in the extreme part of the process in a consumption of coagulation factors. But what is important is that stasis without inside the oxygenator is probably one of the most important promoter of this kind of dysfunction. So that at the end we have an oxygenator failure that is a realistic expression of the thrombosis devices, and this we have to remember that this is a progressive process, as we see in the previous presentation. Every one of us experience the amount of thrombosis that, or the excessive amount of thrombosis during the pandemic wave, in which we see that the probability of pump head exchange, or in many cases of ECMO exchange, was at least twice than what happened in the past. And what was important is that a replacement was seen in up to 30% of the VV ECMO the patient that we treated. But the very important message that we take from literature and from our colleagues is that in many cases we had a late diagnosis of oxygenator failure for several causes. So one of these was the excessive workload. So we need some indicators that come autonomously without deep investigation by the clinician. A lot of efforts have been done to correlate coagulation market to the circuit exchange, so in order to find predictors for circuit exchange. But what we found was about the oxygenator that we have different evidence. There was some lab values and point of care that correlate with coagulopathies that affect the oxygenator efficiency, and other that correlate with coagulopathies that are attributable to the oxygenator, so that begin inside the oxygenator. And the impressive thing was that we had some situations, some patients in which we have effective, even in case of effective anticoagulation, we had unexplained event of devices thrombosis. So when we said we have to change the paradigm in the choice of an oxygenator and the choice in a system, is that what lead to a circuit change is a medical or a technical fail. We know very well that the geometric structure of the membrane oxygenator has a huge impact in a hemodynamic feature and contribute to the development of the thrombosis within the membrane lung. And that the oxygenator design is a leading factor, acts as a leading factor in grow up of thrombotic issues inside the oxygenator, but it can act also as a cofactor, as we see before, in a synergistic way. What is clearly at the end is, in any case, it affects the clinical efficiency of ECMO. So what we see in the past is, and what we see when deciding to move to a new generation of oxygenator, even in my institute, was that we had to understand exactly which is the oxygenator, nowadays oxygenator, that mostly derived from cardiopulmonary oxygenator, and from the point of view of the design, had a single blood in and single blood outlet. What comes from computational flow dynamics analysis is that flow stagnation often occurs far away from the inlet and the outlet port. And this depends probably and mainly because there is near the port is the area in which you have the most high velocity and the better streamlines with the lowest residence time, accumulated residence time. And this evolves in a high risk of thrombosis and an uneven distribution of the blood inside the oxygenator. So when we, the general principle that we think to when we decided to move away from the old oxygenator to the new one for ECMO was that the principle of the optimization was reducing residence time. So we know that flow field is inversely proportional to the velocity. So we should try to find a system that maximizes velocity inside the crossing velocity inside the membrane, but obviously avoiding any turbulence of the membrane. The basics of for the new oxygenation is to be the most hemocompatible as possible. But this is not just correlate to antithrombotic coatings, but also in the design of the flow path and the location of the blood inlet and outlet. So that hemodynamic, the optimization is even blood to obtain even blood flow through the fibrous bundle. We should have an harmonic transition of both the flow pathway and the pressure gradient inside the oxygenator. So reducing stagnation area, increasing the QT ratio, that means reducing the residence time of blood inside the oxygenator in specific area, and so improving gas exchange and spawning more blood in the oxygenation process. So how move to Nautilus Smart Oxygenation? We move considering those principles. We start in the ECMO in the pandemic wave era. We have an early implementation from the evaluation test to a standard clinical use. And what we desired as the desired feature that we try to find inside these devices was the transportability, the possibility to have integrated sensor, because we had with console that are able to manage this this kind of monitoring, and how to deploy in a linear transfer rate, and to have it a standalone system, because we had to fully integrate in some system that we have in our environment that you can see on the picture on the right are the Xenius devices and the Livanova SCPC and the Lifebox. So to fully integrate it during the pandemic wave in order to implement and increment our ECMO capacity. Indication was in the early experience just there was no indication, so we put on the basis of first arrived, first served. And but in the late part, after the initiation of the pandemic wave, we decided to use it for the according to the first result we had in the most critical scenarios. Obviously, we decided to work with the smart module because we need an online monitoring and an embedded screen without any other devices. So what do you expect it has added values by this oxygenator? The first one was that it was the design was for ECMO, so it was an oxygenator, a project ECMO dedicated. This means that it has developed with a smooth streamline, with the principle of smooth streamline, a low thrombogenic profile pathway, a low transmembrane pressure, and a linear P-on-F ratio. On the other side, what we expected was reliable data, as we said at the beginning, and particularly the data that the screen is able to, that the sensor and the screen are able to give us. So arterial and venous saturation, temperature, pressure, delta pressure. But what another important thing was that everything is integrated inside, and there are no cable, and so the most simple way to obtain information. What we found on the data and on the embedded screen, well, The advantage is that we have a standalone oxygenator that is fully alarmable, so you can set up any kind of alarm just in the oxygenator. It has a pressure detection, so P in, P out, and delta P. You can see saturation. You can have a fully saturation evaluation in the screen. It's a touch screen, so no cables, and with an easy-to-use software. And it has integrated batteries that provide you about half an hour of energy supply when we have to move away from the wall energy supply. The system, as we said, it's a very easy. It has a very easy to use software interface. On the picture, on the animation, and the video, you can see the calibration process and the presence of the sensor, as well the power supply cord. The Nautilus standalone is a standalone oxygenator. This comes probably from our colleagues from England. In those moments, every kind of the oxygenator is insensitive to the pump. It means that you can use whichever pump you want and whichever system you want. The question that we had was about just the presence of oxygenator saturation, to understand if just the presence of saturation alone can rely on the principle of less be more. What we have with saturation alone, we have for sure less samples, especially in a hostile environment. We have short time reactive to the ventilation setting modification with a really reliable calibration. And these are the numbers, the indicators that we find inside the embedded screen are quite good, suggestive for quantified recirculation and membrane lung shunt during the ECMO waiting. Obviously, the presence of PO2 control would have been useful in cyanotic in management of cyanotic cases and in reperfusion injury in some patient. What is important is that on this setting, it's quite easy to win, conduct the winning process from VV ECMO. This is how we manage the winning process. That means a reduction in a standard protocol, worldwide standard protocol. But what is incredible is that you can easily understand which is the saturation, the output saturation from the oxygenator while you are reducing progressively the VO2 from 44, 25, 21 and take it off the tube from ventilation. You can see here how the system is providing in a very short time the reaction to the modification of ventilation. Obviously, you have to do a very tight patient control, particularly to understand if on the transcutaneous saturation remains in normal in a normal setting according to the minimal values to be weaned off. About safety online, this is what we experienced several times with the present during ECMO support, but in this case, in this specific case, with the use of the Nautilus oxygenator, is that we had some accidental disconnection during transportation of EV ECMO gas line, as well as we have kink in line with flow reduction of about 40% respect to the nominal flow of the patient, as well as we had some obstruction during prone positioning in VV ECMO. What is important that we have a very early detection of this adverse event thanks to the presence of the alarms that we previously set up for both arterial saturation and venous saturation. These are very clearly audible alarms, and the recalibration process is quite simple. Another things that we find as well very good was the resiliency to anticoagulation withdrawal. We had a couple of cases of ventricular cerebral hemorrhage, so we had to suspend completely heparin infusion for 4 days and 12 days, keeping the flow, keeping a quite normal flow, not full flow, and very low ACT and very low PTT. What we find was a slight increase or a very slight increase of the TMP, and that comes back not to normal, but quite to normal when we resume the anticoagulation to the patient. We didn't know any variation in the gas transfer rate. So some limitation. It's everything good, yes, that we didn't experience any oxygen failure, nor evidence of severe membrane thrombosis, and we didn't experience any severe coagulopathy that was referable to membrane lung with a differential diagnosis. There are also some limitations in the use of these devices. We had, but we identify minor and major limitation. Minor limitations that this oxygenator has probably higher water vapor production, even if we didn't experience any gas exchange deterioration according to the protocols that allow us to do at least twice a day as we part to clean up the fiber from water vapor. And the duration of the integrated batteries integrated during transport in 2 cases had a total exhaust, obviously without any effects on the gas exchange, but in any case we lost the online monitoring. There are some other we consider major limitation. Unfortunately, there is no hemoglobin monitoring, and this could be we consider a major limitation considering our standard system. Unfortunately we have not, but I hope in a short time we will modify this, a driving console, and the absence of data recording or data transfer from the oxygenator to any patient data management. In conclusion, the ECMO course presents various decision-making points, and the early data allows for some timely decision. Non-invasive arteriovenous saturation data can contribute to have a safe ECMO weaning and a safe ECMO management in toto. Data on the trend of transmembrane gradients allow for early detection of any thrombosis devices, but this is not exhaustive, so we have to anyway control different data. And these aggregated data allow to effectively evaluate both the oxygenation performance and the clinical contribution to oxygenation. Thank you for your attention.
All right. Thank you very much, Mauro, for sharing the San Donato experience with all of us. And we are right on schedule, which is awesome. So let's move on and let's go on with the Q&A time. So I've gathered pretty much all the questions here in the Q&A. And the first, so can I also ask Kalynne? Oh, yeah, perfect. Thanks for activating the camera again, Kalynne. The first question is actually for you. What type of anticoagulation did you use? And what were your goals for measurement?
So generally standard anticoagulation is heparin. And our goals are anti-10A levels of between 0.2 and 0.3 throughout, and then obviously the heparin heparin level is adjusted accordingly to fit that parameter.
Okay. Let's switch to Mauro now. So Mauro, this is a very practical question. So you mentioned that you have a little bit more water vapor production. How do you practically solve that on a daily basis? What do you actually do then? Can you share some more practical information with us?
Of course, it's a very easy way to solve the problem if we can consider it a problem, because as I said, we didn't have any major issue in gastric change, differently from pediatric experience in which something can change. We have just we have a protocol that the indication is to do a sweep out gas with increasing sweep to 10 liters for twice a day, or in any case, if we have any issue with the gas transfer, is the first act that we implement in order to understand which is the causes.
Okay, thank you. Back to Kalynne. Kalynne, so we have a comment here that Medtronic claims to have a low resistance to blood flow, so a low delta P. And the question is, this is in comparison to what? So Quadrox is approximately 5 millimeters per mercury per 1 liter of flow, and then Nautilus is 10 millimeters of mercury per 1 liter of flow. So the participant here in the webinar shared that while switching from Quadrox to the Nautilus oxygenator, he actually found a bit of a higher resistance. What is your comment on that? Do you have the same findings? Please share your feedback on this query.
Sure. So I would say the Quadrox and obviously the Nautilus are excellent examples of oxygenators that have low transmembrane pressures. I think off the top of my head, the oxygenator that I would say comparatively, and one that we have obviously used at our unit is a Eurosets, which has transmembrane pressures that easily exceed over 100 millimeters of mercury. And I suppose that's the major difference when looking at, say, other oxygenators. It's that significant jump in transmembrane pressure that exists in other oxygenators.
Okay.
Yeah, I suppose that's the only other oxygenator we've used that I can think of at the top of my head.
Okay. Another question for you, Kalynne. So you mentioned that the first Nautilus was used for 164 days before you needed to exchange it. The question here is, did you afterwards you also use the Nautilus, or did you use another oxygenator?
I suppose
if it's the case that you used another oxygenator, what was the period between the other exchanges then?
Right. It'll be, I think, a little bit easier to answer this question if I pull up that specific slide, if that's okay.
Absolutely, feel free to do that.
So just looking at the timeline. So as a Brompton, we normally retrieve our patients on CardioHelps. So essentially he was changed from a CardioHelp to a Nautilus, and that was due to a high or an increased trend in transmembrane pressure. Our threshold is a little bit low, or quite significantly low, with CardioHelps, just because of the coupled oxygenator and like pump head mechanism. So once your membrane starts failing, generally your flow fails quite quickly. So we just have quite a low threshold for an increase in transmembrane pressure. And then subsequently he was changed. So he obviously was changed to the Nautilus, was on for 164 days, and then was changed to another Nautilus oxygenator. And that was, so essentially only 2 Nautilus oxygenators throughout his whole run. So the balance would have been CardioHelps for varying reasons. So he was essentially on ECMO for so long because he had a queried lung transplant candidacy. And so we changed him to a CardioHelp eventually, just to improve mobility during his physio sessions. So he was walking around and it was just a bit easier with the CardioHelp. And then was then transferred to Harefield, who primarily used CardioHelps. I can't speak too much as to what happened at Harefield with regards to his circuit changes. I can only quote what was put in the notes when we did actually change his circuits out. And for the most part, it was increased trends in transmembrane pressures, which again, quite conservative with when we look at cardio helps. So I hope that answers the question.
I think it does. I think it does. Otherwise, I will see another questions popping up in the Q&A about this one.
Fine.
Mauro, let's switch back to you and focus a little bit more in detail on the smart version with non-invasive integrated monitoring. What is your perception on the pre and post membrane saturation measurements in VV ECMO? Is it useful to detect recirculation, for instance? What are your comments on that question? Sorry.
Considering we miss in this setting of only the oxygenator, the part related to the venous saturation of the patient, central venous saturation, in any case, in our experience, was quite common to detect early any sort of recirculation phenomena. Obviously, not fine phenomena, but macro phenomena is quite easy to detect. You immediately see a venous saturation growing up, and in those configurations. But obviously, depend even also from the configuration, cannulation configuration that you have. In our setting, we have a femoral jugular cannulation, so femoral drain and jugular return to the patient. So it's not so easy to have cannulation, but or recirculation. But in some cases, like femoral VV, we had some VV femoral during COVID to improve pronation. It was very helpful to detect this phenomena.
Okay, and another question for you, Mauro. I'm not sure if you guys are doing that in your hospital, but just in general, if you would have an ECLS patient and you wake up the patient to mobilize the patient, what do you think about these saturation measurements? Could they also be a warning when you're mobilizing the patient to take a rest and then move on? Can you comment on that?
Any information for me is a good information in general. I consider that it's a very good way to prevent the issue. So as I said at the beginning of my presentation, we have to move to a new paradigm of ECMO system. So we cannot rely on observe something that is happening or try to prevent, but we have to understand exactly what is going to, which are the causes that lead to an adverse event. So any information like the one or the situation like the one you mentioned, it's in this condition, any repositioning of the patient or any transportation of the patient, when you have this kind of information directly on the oxygenator, make your life much more easier.
Okay, thanks for your comments, Mauro. I actually have a question for both of you. It's a really practical question. What do you think about the air handling capacities of Nautilus in general? And let's start with Kalynne.
Just generally, anytime we're prime, I would say it's quite an easy oxygenator to prime and de-air. There generally no concerns, stubbornly trying to recirculate for hours to try to get air out or anything like that. And even in our wet labs, trying to remove air from the oxygenator at its air handling port is quite easy and quite effective. And with my own experience, I can't think of any time that there's any air sitting in the superior part of that oxygenator when priming. So I would say from an ease of priming perspective, it is quite good.
You feel the same about the air handling capacities, Mauro?
Absolutely, yes. I have to agree completely with Kalynne. Obviously, we are the only experience that I can give you is about priming, because fortunately we didn't have any issue about air handling for different causes. Because our system has a preload control, and so we didn't fortunately experience any debubbling situation of the patient for an accident. Anyway, I confirm what Kalynne said. It's very easy to prime oxygenator. Even also the bubbling process is quite easy. From my point of view, it's a very good way. It's a very good thing because in some settings, in some hospital settings in which you don't have the number that have, for example, in the Royal Brompton, and in which you cannot keep an oxygenator ready, already prime in the setting, these devices allow you to be filled at the last moment, and you don't lose time.
Okay, thank you. Let's see. Do we still have some open question? Yes, we have. Back to Kalynne. So Kalynne, you presented a great case. I mean, 164 days with just one oxygenator. That is, I would say exceptional, but it isn't, because I have attended a few symposia myself, as you know, and I talked with lots of perfusionists that are using Nautilus, and they acknowledge that you can do much longer with Nautilus compared to other oxygenators on the market. Is that true? Do you feel the same? Are there more cases where you have used a Nautilus ECMO oxygenator for a prolonged period of time? Or was this your exceptional case?
I think,
and Mauro, you can answer also on that question after Kalynne.
So yeah, this case I think was quite an exception. I'd have to look at the balance of our data to see if there was anything of that nature. I think this specific patient rang true because we were kind of aware of him because of his lung transplant candidacy and how long he was on, and during COVID. You know, he was the first person I thought of when I thought of this Nautilus ECMO run. So I can't quote exactly the average time that a patient spends on a Nautilus. It's obviously always how long they end up being on ECMO. But I will say from experience, or from what I've noticed, is that it's very rarely that we end up changing circuits for patients that are on a Nautilus oxygenator, for the reasons of a failing oxygenator. Our unit, I would say, primarily over the last 2 or 3 years that I've been working there, we primarily use CardioHelps and Nautilus oxygenators, and Eurosets. And so the CardioHelps, we do, like I mentioned before, we do have a lower threshold just because of how flow rate is compromised when the membrane starts failing. So comparatively, yes, I would say the Nautilus is better in terms of long-term long-term use in our patients, for sure.
Have you experienced the same as Kalynne, Mauro?
Obviously, we don't have the same number of Royal Brompton, and so we had some support of more than 30-40 days. Not 160 at all. This is an exceptional result. So my congratulations to your team, because it's a very hard job to keep a patient on ECMO for so a long time, even with this kind of changeover of the system. But in any cases, what we found, as I said, we didn't experience, fortunately, we are very lucky. We didn't have to change oxygenator in our experience. Probably for the shape of the oxygenator, probably because we are just lucky, probably because we have experience on the coagulation. We get experience from our job before, from our background. But in any cases, the perception that I had, and I underline again, we started to use the Nautilus on the worst cases and in the most critical scenarios. We don't have in our environment, we don't have any more Quadrox, so I cannot say, I cannot compare the two systems, but with our system, we feel much more safer with this oxygenator, at least for the numbers that we had and the experience that we had.
Okay, let's we're running out of time, so let's do one final question. And I just saw it popping up in the chat. So a participant is wondering if your institution, Kalynne, is taking into account the costs of the Nautilus oxygenator over others. Can it be more cost effectiveness over long terms compared to others on the market, or others that you have been using? That's basically the question that came up in the chat, and I think it's a good one to end this webinar with.
So offhand, the actual cost difference between the oxygenators, I would be lying to say that I actually know what they are. I mean, fundamentally, cost is obviously something that needs to be taken into consideration, and I think it would be easy to say, yes, if you have oxygenators that if you need fewer oxygenators on your unit because you're changing them less, then obviously it's going to translate to a more economic outcome for your hospital. But yeah, like I said, off the top of my head, I can't spit out any figures with regards to costs or savings between oxygenators.
Okay, that's fair. Thank you very much. All right, our time is up. We're a little bit over time, so I want to thank both speakers, Mauro and Kalynne, for being here in this EMSECT webinar sponsored by Medtronic to talk about the European experiences on using Nautilus ECMO oxygenators. And I hope everybody enjoyed the webinar, and we do look forward in welcoming everybody here and also others in one of our next webinars. So thanks again for being here with us, and enjoy the rest of your day. Bye, everybody.
Thank you very much.
Thank you. Bye, everybody.
Bye.